Good afternoon, and welcome to Ask the Doc, where live viewers have the opportunity to ask questions of experts in Alzheimer's and dementia research. My name is Megan Whitbrocht, the new Associate Director of Education at UCI Mind. UCI Mind is part of a national network of Alzheimer's disease research centers designated by the National Institute on Aging and part of the National Institute of Health. Today, we're fortunate to be joined again by Dr. David Seltzer, who is an esteemed professor of psychiatry and human behavior in the School of Medicine at UC Irvine. He is also the clinical core leader for UCI Mind. Dr. Seltzer received his medical training from the University of North Carolina and completed a psychiatry residency and neurobehavior fellowship at the UCLA Neuropsychiatric Institute and Hospital. He is a distinguished fellow of the American Psychiatric Association. Dr. Seltzer's research interests include neuropsychiatric symptoms in Alzheimer's and using neuroimaging as a tool to detect clinical symptoms of dementia. Dr. Seltzer, welcome back, and thank you for joining us today to discuss your research. And welcome to our live viewers. If you're attending live on Facebook or YouTube, you can participate in the Q&A with Dr. Seltzer by typing questions in the comment box accompanying the video. Please note that whatever you post on the internet will be linked to you and visible to others, so please post responsibly. Okay, before we start today, I thought it would be a good idea for us to address the elephant in the room, and the elephant being Aduhelm. On Monday, the FDA voted to approve Aduhelm for the treatment of Alzheimer's disease. Dr. Seltzer, would you be willing to talk briefly about what Aduhelm is, how it works, and what this FDA decision means?
Sure, I'd be happy to, Megan. It's a pleasure to join the group today. It's nice to be back to Ask the Doc, and I hope the information today is helpful to folks who are viewing. Yeah, with aducanumab, which is the generic name for what the brand will be called Aduhelm, is a monoclonal antibody. That is an antibody that attacks the amyloid protein, the abnormal protein of Alzheimer's disease in the brain. And on Monday, as you mentioned, the FDA approved Aduhelm for the treatment of Alzheimer's disease. This is a really exciting development. I mean, it reflects now a decade or more of work looking at how can we best remove amyloid, the bad protein of Alzheimer's disease, from the brain. And this opportunity to use antibodies that attack the amyloid and pull it out of the brain has shown promise for a number of years now, and now some successes. So it's an exciting development. It reflects all these years of effort, but I think we can see it best as the first of several future steps to better treat or prevent Alzheimer's disease. But as a first step, there's some questions about the role of Aduhelm that remain. You know, one issue is that the FDA approved Aduhelm on the basis of its being able to reduce amyloid plaque in the brain. As we're talking about, that's a good thing. But it's considered in FDA language a, quote, surrogate endpoint, meaning that it's a marker for what we hope to be clinical benefit, but not necessarily in these trials a demonstration of clinical benefit. So in brief, what this means is that the FDA agrees that this compound will remove amyloid from the brain, and the data clearly supports that. What's a little unclear is how that'll be translated to clinical benefit, memory, perception, problem solving. You know, these people in the studies had mild cognitive impairment due to Alzheimer's disease or mild Alzheimer's disease, were treated for 18 months, and they had to have an imaging study that demonstrated amyloid in the brain to enter the trial. And the data show that there was clearly a dose-related decline in brain amyloid on imaging over time, and the FDA approved on that basis. There was some evidence of benefit on cognition, memory, language, perception. In some of the, in one of the studies, there were two big studies, each with about 1,000 participants each, that there was some evidence of benefit on these on memory tests in one study, but not in the other. Similarly, the other functional skills, other things that we hope for improvement with treatments for Alzheimer's disease, there was mixed evidence of benefit there. So the bottom line is that the mechanism worked, but whether it's translating to clinical benefit is a little bit less certain. Hence the controversy that you may be aware of, that people were wondering about, gee, should the FDA approve that? Because they weren't approving it based on clinical benefit, but on the surrogate endpoint. So that's more regulatory things than you may want to hear about, but kind of frames why the controversy has been the way it is. We have to keep in mind that there are side effects with all treatments, including aducanumab or Aduhelm, that there's evidence of small vessel brain swelling in a fair number of people who are treated with this compound. And it usually occurs early in the treatment. It's usually without symptoms, which is a good thing. But small amounts of brain swelling are obviously something to be aware of. And it doesn't seem like there are long-term consequences in the majority of cases. But it requires, the FDA has required MRI scans before treatment and twice during treatment to make sure that there's not significant amounts of brain small microhemorrhages occurring. So it's something that's a little more complicated than it's taking a pill. It's an IV infusion, so it requires going to an infusion center and getting the drug that way. There's some practical issues involved. One is that probably to be treated, you would need to have an amyloid scan, brain scan. As I mentioned, there's a monthly infusion, MRI scans, and clinical follow-up would have to be pretty careful. Another piece that's uncertain to the field is whether insurance companies or Medicare will cover treatment. It's expected to be a relatively expensive treatment, and it's unclear how that would be covered in general. So, I think most folks should consider their own personal circumstances and talk to their doctor about the likelihood of them receiving benefit, to learn a little bit more about these kinds of things we're talking about and what it means to them personally, remembering that this is for early. The data comes from people with very early Alzheimer's disease. And the label says Alzheimer's disease, period. So it would be, I suppose, authorized to be given for anybody with Alzheimer's disease. But I think the evidence supporting benefit for those with more advanced symptoms is probably not there, so wouldn't be wise. So hopefully that's a reasonable introduction.
No, that's fantastic. I think we're going to pause this conversation with the idea that in 2 weeks, on June 24th, Dr. Joshua Grill, the director of UCI Mind, is going to dedicate a full episode. It's a special Ask the Doc episode that we're going to spend the entire time talking about Aduhelm and the implications of the FDA decision. With the remainder of the time today, I want to get back to your research, Dr. Salzer, because you're doing fantastic work and it deserves its own show. The last time you were a guest on Ask the Doc, you mentioned your research on behavioral symptoms as a possible sign of dementia. So let's dive into that for the remainder of the time. Okay, so are certain behavioral symptoms more commonly associated with specific forms of dementia?
Yeah, it's a good question. And I think to frame this conversation, we need to be thinking about, what are behavioral symptoms, and to remember that the hallmark of Alzheimer's disease are symptoms like memory difficulties. That's sort of the queen of Alzheimer's disease. But we realize that along with these cognitive memory, perception, problem solving difficulties that people with Alzheimer's disease have, there are also non-cognitive or behavioral symptoms, things like anxiety, mood changes, irritability, some disinhibited or agitated behavior, sometimes later in the course of illness, apathy. So that when we think of Alzheimer's disease as a syndrome, it includes different kinds of symptoms. And we're talking now about this category of non-cognitive symptoms. And that to answer the question, that different forms of dementia have different kinds of behavioral symptoms. That, for example, in Alzheimer's disease, sometimes we see, and this doesn't affect everybody, but just kind of their patterns, and more often than not, challenges with apathy, just disinterest in things, not necessarily depression, sadness, hopelessness, but just lack of enthusiasm or motivation, anxiety, maybe some mood symptoms early on. And then later on in the course of illness, some are unfortunately affected by delusional thoughts, beliefs that others may not agree with, and some of the behavioral problems such as agitation that I alluded to. So that's kind of the Alzheimer's pattern. In other dementias, for example, vascular dementia, those who've had a fair amount of cerebrovascular disease, it's a different profile of these non-cognitive or behavioral symptoms. Apathy is much more common. Depression is much more common than in Alzheimer's disease by many fold. There's a whole concept of vascular depression, and that those that have small vessel cerebrovascular disease that may be driving the memory difficulties also contributes to mood changes in this population. So vascular dementia is a little different than Alzheimer's disease. A third that you may be familiar with is dementia with Lewy bodies or Parkinson's disease that sometimes is also associated with dementia. And in that group, hallucinations are quite early. Visual hallucinations are really part of the diagnostic framework of dementia with Lewy bodies. So yeah, the pattern differs across these subtypes, probably based on what part of the brain is affected and in what way. And each of those dementia syndromes has its own pattern of brain difficulties as well. It's emerging with not only the memory difficulties, but also these behavioral symptoms.
Very good. Do you, how frequently do you see behavioral symptoms in Alzheimer's disease?
Yeah, it's quite common, and most in the field believe that most people over the course of their Alzheimer's disease will almost universally develop some of these behavioral symptoms that may be subtle or they may be more substantial. That some things are very common. I mentioned apathy, anxiety, and mild mood changes. Those are probably some of the more common symptoms in Alzheimer's disease. And those are happening in probably 40% or more of people with Alzheimer's disease at some point over the course. And these are important because we actually know that these behavioral symptoms are predictive of future cognitive decline. That is, those who have behavioral symptoms are at slightly greater risk for more rapid progression of their degenerative process. That not affecting everybody, but across groups of people. And probably, as everyone knows, that the caregiver distress and issues about hospitalization or alternative placement in skilled nursing facilities, for example. I mean, those are really driven by caregiver distress and challenges that face those who care for Alzheimer's disease. And as you can imagine, the behavioral problems, particularly later in the course of illness, things like agitation, great irritability, oppositional things that are really difficult for caregivers to manage. So the frequency is high, but their impact is quite high as well.
Mm-hmm. So let me go back for a second. So if I understand you correctly, patients with Alzheimer's who experience behavioral symptoms are at higher risk for declining more rapidly?
Yeah, if you look at groups of people with mild cognitive impairment due to Alzheimer's disease or mild Alzheimer's disease, and crudely group them into those who have more behavioral symptoms and those who have fewer behavioral symptoms, the group with more behavioral symptoms are more likely to decline in memory over the next few years, for example. So that it suggests that there's something about the behavioral symptoms that are a marker for perhaps a more aggressive illness, but that's really speculative. But it's been something seen in a couple of different studies now, which is interesting and highlights the importance of these symptoms for clinical progression as well.
Mm-hmm. Okay. So do you ever these symptoms before a person would experience the symptoms more commonly associated with AD or Alzheimer's disease, memory problems, judgment, things like that?
Yeah, it's a great question. I realize I've sort of blurred things a bit about these kind of neuropsychiatric or behavioral symptoms. And we've been talking thus far about when you have clinical Alzheimer's disease. But another frame of reference comes from evidence recently that people who have late life depression, for example, are at greater risk for developing Alzheimer's disease over the next decade with memory problems, et cetera. So it appears that some of these behavioral symptoms, particularly depression and anxiety, appear to be risk factors for developing Alzheimer's disease. Now, no one's really clear about, is it truly a risk factor, i.e., if you have a depressive episode, that adds to the likelihood of developing clinical Alzheimer's disease? Or is it possible that these symptoms are early expressions of the Alzheimer's process? That is, it just happened that these mild symptoms, behavioral symptoms, just happen to be the first things to emerge as the Alzheimer's process unfolds, with memory being a little bit later. The field's kind of uncertain about that, but it's an interesting phenomena that having late life depression increases your risk for developing Alzheimer's disease by about 50%. So it's really, in some studies, it's not a trivial relationship. There's interesting ideas about why that might be, and some evidence that things like inflammation may be worse in those with depression, brain inflammation, subtle brain inflammation, on the basis of the mood disorder, and that may exacerbate the Alzheimer's process, but those are still somewhat speculative. But it's an exciting opportunity to kind of look at what is really happening over the course of Alzheimer's disease, and can we, if it's an early expression of illness, would treatment or intervention for these behavioral symptoms actually forestall cognitive progression, for example? Pure speculation at this point, but some interesting things to consider.
So you're suggesting that perhaps treating the behavioral symptoms may delay the disease or slow the disease, possibly, just a hypothesis?
Yeah, it's speculation. There's no evidence of that right now. There's some evidence that people with depression over the lifespan, that the number of years of untreated depression is correlated with risk for Alzheimer's disease. Moreover, in that inflammation paradigm that I alluded to a minute ago, that those who had the length of time treated with an antidepressant reduced the inflammation. So there's some mechanisms there and some hints, but we just don't really know. I really put it out there as an opportunity to not only understand how can we best, help folks who have symptoms of anxiety and depression. There's some treatment benefit there in and of its own right, but also it may have an impact on the future course of cognitive decline should they be headed in the dementia direction.
Very good. Is there something different happening in the brains of people with Alzheimer's who experience behavioral symptoms compared to those who have the disease but don't experience similar symptoms?
Yeah, another good question. And this is more of a research interest and issue, but it helps us understand that these behavioral symptoms are really a fundamental aspect of the degenerative illness, that Alzheimer's disease includes these different sets of symptoms, and that the brain relationships that we've seen in other labs really demonstrate that there's almost a distinct brain pattern of changes associated with symptom clusters like apathy, like delusional thoughts, like anxiety. And we've published some work in this area using fluorodeoxyglucose PET imaging to look at regional brain metabolism. And if you look at those with Alzheimer's disease who have apathy, for example, and those who don't, we can see differences in how their different parts of their brain are operating. So there are these brain signatures that provide a link between how the brain's working and the kinds of symptoms that people have in this behavioral realm as well as cognitive realm. There's also even interest in things like genetics. It's there are genetic contributions to the expression of these symptoms as well. So it's the brain, on the basis of its genetic development, is potentially vulnerable to some of these symptoms, and someone else with a different genetic makeup may have less vulnerability to the symptom. So it's the illness talking is the bottom line.
I see. So would the brain pattern of someone who's experiencing apathy be different than someone who's experiencing aggression or delusions or disinhibition?
Yes, and that in that paradigm, I talk about looking at those with or without a symptom. For apathy, it tends to involve the front part of the brain and the middle front part of the brain and the base of the front of the brain. With greater decline in activity in those regions, you're more likely to have symptoms of apathy. In contrast, agitated behavior, for example, is a little bit more broadly based, more prominently right hemisphere rather than left, and includes some other parts of the temporal cortex, for example, a little bit further back in the brain and a little bit lower. So temporal and right frontal deficits are associated with symptoms like agitation, whereas apathy is more of a medial frontal syndrome.
Okay. You mentioned the PET. Are there other tools that doctors can use to detect behavioral symptoms in the brain? MRI or EEG or things like that?
Yeah, I mean, these are mostly research opportunities again, and don't always have impact on clinical care. But that things like MRI shows in the same regions small thinning of the cortex in these regions, suggesting that it's not just a functional change that's driving the behavioral symptoms, but a structural one as well. That there's just everybody's Alzheimer's disease is a little bit different and affects, there are characteristic patterns among everyone, but some people have more or less atrophy in certain parts of the brain. So structural MRI scans show some relationships as well. Even the amyloid PET scans that are being done now to identify candidates for anti-amyloid treatments, those have demonstrated. Katrina Lewis, who you may recall was part of our group last summer, and a medical student at UC Irvine, did a really nice analysis of the extent of brain amyloid in a large sample of people as part of a national study and relationships to anxiety and depression, and showed that those who had more amyloid in the brain on amyloid imaging, these are folks who are cognitively normal, were more likely to have symptoms of mild anxiety, suggesting that even tools like amyloid imaging give us a hint about who may be susceptible, but it really doesn't have that big an impact on how we consider or treat people who have these symptoms. It just gives us, it really is a window into what might be driving them. And just so we learn more about what Alzheimer's disease is from the brain point of view, it provides opportunities for treatment targets. It also provides an opportunity to look at what I'll call phenotypes. Some people develop agitated behaviors later on in the course of Alzheimer's disease. And agitation is really a very mixed term, as you can imagine. I mean, what is agitation? And I think if you ask a caregiver, they know exactly what it is if it's happening, but it's the field has struggled with kind of trying to understand what's happening and how to treat it based on really what it is. And if there are brain signatures of particular kinds of agitated behaviors, that helps us focus in on what may be a more coherent subset of symptoms that reflect brain pathology that are more amenable to a more consistent treatment, rather than just sort of applying a wide variety of medications or other behavioral interventions that are often more successful in managing some of the symptoms. So it provides an opportunity. These research studies provide a window into what's going on with the brain, as much as in 2021, more that than telling us, oh, this person will have X symptom and this is how we treat it. We're not there yet, but that's the goal.
Very good. Can I go back to Katrina's research for a second?
Absolutely.
And you may have mentioned this. Were you able to determine if this mild anxiety had been long-standing? So participants were showing symptoms much earlier in life, or was this kind of later, possibly with the development of the amyloid plaques?
Yeah, it's a great question. And there are many, Katrina was able to control for a whole variety of factors, age, sex. One thing that she wasn't able to control because we didn't have the data was previous history of anxiety, for example. And we don't know whether the folks with this relationship had more or less anxiety over the course of their lifespan, or when it occurred. So that remains an unanswered question. We benefited from having a very large data set, but it wasn't data that we had collected here and embedded questions like that would have been really important and useful to have. But we did what we could with the data available. And it really just demonstrates a cross-sectional relationship, a one-time relationship. And these are folks who don't have a whole lot of anxiety. The relationship with increased amyloid was pretty subtle. It was statistically significant, but somewhat subtle. And again, these folks didn't have severe anxiety or depressive symptoms. So I want to be sure that we understand that the viewers understand it's not that link is a little subtle and helps us again understand how the brain's working, and that amyloid may be contributing not only to the progression of Alzheimer's disease, but to some of these symptoms like anxiety that come with it.
Very good. Okay, it looks like we have a question from YouTube, and as I can interpret it, I think the person is asking, is it possible in dementia for someone to sort of swing between having mood swings or maybe aggression, depression, things like this, and then go to being unable to speak or understand, catatonic in a sense?
Yeah, it's a good question. I think catatonic I would consider a little more extreme, and the answer to that would probably be that's unlikely. But what is likely is that people change day to day. I mean, I think we have to reflect that all of us have our own personality idiosyncrasies and susceptibility to mood, things, how we respond to the environment and things around us socially and emotionally. And that people with Alzheimer's disease tend to have some of these more dramatic symptoms, but it's not uncommon for them to change hour to hour, day to day. And some studies have shown that if you have, for example, anxiety at one point or delusional thoughts at one point in your illness, the next day or week they may wane, but they tend to come back again. So people sort of have a predilection, if you will, for some of these symptoms based on brain function like we're talking about. But in real life, there's a lot of variability day to day, absolutely. And that one characteristic is something we call lability, or the inability to, or the challenges in maintaining a mood and a more extreme reaction to other events. And some people with more advanced Alzheimer's disease really have kind of a distress eruption sometimes based on something that just triggers distress in them, but it really is a little out of proportion to what you'd expect. So yes, that can clearly happen. Not catatonia. I think there's something else going on in somebody who becomes catatonic.
Good. I want to, one more question. I want to ask you about how your research on this early behavioral changes in people with Alzheimer's disease could help people in the future. How is your research sort of potentially helping clinical care in the future?
Yeah, it's a great point. And as I've alluded to, I mean, much of our research is trying to understand how the brain works and how brain function translates to these symptoms. But I think as far as impact on people and clinical care, one important thing is awareness. We tend to think of Alzheimer's disease as a memory disorder, and that sometimes these behavioral symptoms are sort of considered, secondary symptoms, or they happen later, or it's just kind of what happens when people are confused. When I think part of the point I've made today is that it's actually an expression of the illness itself. And that awareness of these things, looking for it, recognizing that you look at when people make decisions about institutionalization, hospitalization, emergency department visits for people with Alzheimer's disease, it's the behavioral symptoms that drive those, not memory changes. And I don't mean to diminish memory, but to recognize that there's a broad set of symptoms that can happen. So we need to be looking for them, understand them, ask about them, and consider how we can help them as well. So I think that's one thing. Research-wise, it's also nice to understand what's causing them, because understanding causality gives us opportunities for treatment. And I think even if we don't know the specific targets right now, we'll know more about that as time goes on and have opportunities to intervene early, like we alluded to a little bit earlier in the session, that it may be that intervention in some of these behavioral symptoms actually improves cognitive outcomes. So not only is it good to consider and treat anxiety, depression, just period, independent of Alzheimer's disease, and there's obvious benefit there, but it also may have an impact on the course of Alzheimer's process, and that's something we'll just learn more about over time. So I think those are the main clinical benefits, predominantly awareness. Think about these things. They're important.
Yes. Well, Dr. Seltzer, thank you again for taking the time to chat with our audience. We really appreciate it. And thank you to all of those who attended today. You can access this episode and past episodes of Ask the Doc on our YouTube channel or on Facebook or on our website. And don't forget, in 2 weeks, we're going to have a special episode with Dr. Joshua Grell, the director of UCI Mind. He'll be joining the program to discuss at length the FDA's decision to approve Aduhelm and the implications of that decision. In the meantime, to learn more about research at UCI Mind, you can visit our website and consider signing up for the UCI Consent to Contact Registry to learn more about research studies that might be right for you. Take care, and we'll see you in 2 weeks for the special Ask the Doc episode on Mindcast. Thank you.